I would do one play, and I would get hurt every season. So I kind of resonated with it. We're going to be in session 2. Thank you guys for coming back. The handouts are coming around, so you'll have everything we talk about. So most of you were here last time, so we talked about basically the note. And I did encourage you, I think, to read the book House of God. Did I tell you about that? So House of God's like the definitive book on just sort of why doctors are such jerks and cynical. But they do have a phrase in there called buffing the chart. And really that's what note-taking is. We just got to have a nice reflection of what happened with the patient encounter. So, yeah, come on in. And so that's what we kind of talked about last time. And we're trying to get all of this put online so you can review it and try to get it better. So please give us feedback on how we can make that better. Understand that our end goal is to have a note that reflects what happened during the medical treatment. And that's the 3 things, right? I'm going to be asking you guys all the time, but the note has got to reflect what the patient care was, the billing, because you don't want to work for free forever, and medical legal. So 10 years from now, when you get sued, you have a chance. In a perfect world, it's been recommended to try to get the note signed off in 2 hours. It's very tough for me to do that, as I'm getting new scribes in and trying to do that, so I end up having to do them at the end of the day. The worst is that you have to at least get it done within a month. That's what CMS, the Center for Medical Services, says. But the sooner you get it signed off, the better. There's times where, because now everything's time-stamped, so if you sign it off 2 weeks later, we just had this case where somebody signed it off late, the patient's now questioning how much does he remember of that versus what happened. So understand that everything's time-stamped. Whenever you get into electronic health records, your name is on there. We'll talk about HIPAA security and stuff. So just understand that you're sort of being watched. And what I expect all of you to become, because you're going to reflect me and I want to get a good grade, is that you're going to really work hard to get a good note so that your doctor, provider, just so you know, doctors are doctors, and then use the word provider for nurse practitioners, physician assistants, other allied professionals. So doctor and provider, we want to be publishers. We don't want to edit. Like I have to fix is it left or right, male or female. I mean simple things that just drive me up the wall, because if that doesn't go well, the rest of the note, because in the attorney, when you get deposed, they're going to go through and well, if you don't even know if they're male or female, how can the rest of this note be good at all? So it's a very legal document. And then the other is that you have to be very careful how you describe the patients. Like I never use obese. That just sounds, because the patients actually get access to the record. And you just have to be, I think, a little sensitive to some of these words. Like I say, they're above their ideal weight. So there's phrases you can use that just aren't judgmental at all. And we talked about certain abbreviations, like I want you to use abbreviations, but SOB in a bar means something different than in the ER. So it's short of breath versus the other. So I don't use certain ones like that. So medical terminology is very, very important. It's almost like a whole new language. And a lot of that has to do with, a lot of the medical words are based on Greek and Latin roots. So I don't know how many of you took 4 years of Latin, but I did. And we said this before every class. Latin is a dead, dead language, dead as it can be. It killed all the Romans, now it's killing me. Just always say that and learn. And so I just wanted to let you know about the phrase Latin-wise that we came up with, which is what we sort of base all of our life on. Again, we're just a bunch of jerks that came up with this, but semper ubi sub ubi. Anybody know what that means? It turns out that Latin makes everything look good. Always wear underwear. So it's like, as long as it sounds good, people will believe you. So a lot of times, I joke that we cure through syllables. So you would all think that this has a certain color. What color would it be? Red? No. It actually is erythematous. That's 5 syllables. You're paid by the syllable. So I've never seen a red throat. It's an erythematous throat. So this is your kindergarten color. So yellow is xantho, chloro is green, cyan is red, or like cyanotic, they're blue-lipped. Erythematous, 5 syllables. Leuco is white. Melon, like I just had, unfortunately, someone diagnosed with I call it melanoma, but it's melanoma, and so we got to work to keep them alive. So understand, like, everything has a bigger word, and so it is going to be a bit frustrating, but that's just part of the fun, or part of how you can kind of really look like a star. So I encourage you not to learn Latin, but to learn the roots, and maybe learn some of the history of the words. Like, for example, hypodermic, or not sorry, well, hypodermic means under the skin, underdermic. So what about, have you ever heard of someone being a hypochondriac? Anyone know, what does that mean? Anybody?
Always think you're sick.
So hypochondriac means, you know, we say, oh, you're a hypochondriac, you always feel like you're sick. Well, let's break down the word. What's hypo? Under. What's chondro? Cartilage. You always feel sick in the stomach. So it's hypochondriac means sick in the stomach. A little darker one, when someone's hysterical, what does that mean? What does that mean when you're hysterical? Kind of crazy, a little over-emotional. I never use that word because what's a hysterectomy? Take out the uterus. Hysterical means you're acting like a uterus. Like, I don't use that. It's very, gender bias. So just as you go through life and you see, like, I've never used that word. Rule of, and then there's little phrases too, like rule of thumb. You guys ever heard that phrase? That comes from a very dark thing, that if the stick you hit your wife with was less than the size of your thumb, you didn't get prosecuted. So I never use that phrase. So once you learn this, like, the whole world gets really weird. But anyway, I don't recommend that you learn Latin. I don't recommend you learn Greek, but I recommend you learn the roots. So there's a lot of little phrases to do that. And then you can break down any word and you just kind of know it. So, and for whatever reason, patients like it if you can give them a big word. Like, for example, when you listen to a noise in the carotid artery, you call it a bruit. It turns out to be French. Bruit just means noise in French. But if I say you have a noise in your carotid artery, it just doesn't sound as good. Oh, you got a carotid bruit. Oh, carotid bruit, I got something. So it's very interesting how the words are very important, and then you have to be very careful how you use them. So I would highly recommend keep learning those things. There's a lot of Quizlets that can help you with that. Besides that is also the medications. Because as you know, medications are a tough thing, and there's medical terminology for the medicines. What I like about medicines is you kind of figure out, like, why do they call it that? Like, anybody ever heard of Lasix? It's a drug that's out there. It comes from the fact that it only lasts 6 hours. Lasix, lasts 6 hours. Warfarin comes from WARF, which is Wisconsin alumni research. And I like the medications, I can't get any off the top of my head, that are named after Doctors Y. Like, oh, I'll just go with or something. So it's a tough thing because the medicines basically all have two names. They have the generic and then they have the branded. So it's sort of like, sometimes you say Kleenex, but it's actually Kirkland or something like that. So that's something you're going to really have to struggle with, because the number one thing that gets, a lot of people get killed in medicine, unfortunately. Not purposely, but by mistakes. And a lot of it has to do with medications. I joke that the only medication that is QID, which is 4 times a day, that helped anyone was one they didn't really need. Because no one could take it 4 times a day. So we spend a lot of time, especially with our seniors, like, well, what medicine are you on? What are you taking? How often are you taking it? Frankly, they just kind of say, well, I take this pill, or it looks like that, or this kind of stuff. So I encourage you all to download. This is a free app called, these are the generics, so the names. One is Eliquis, which is a blood thinner, and then it's Paxaban. And so you just see each one. So officially, you're supposed to use the generic names, but people kind of interchange both of them. I just kind of do the best you can with them, but understand that that's probably where you spend a lot of your time, is what all the meds are on, and kind of, you can almost, by what their med list is, figure out what all the diseases that they have. And so we encourage you to kind of use this. It's called Hippocrates. There's a free version, that's what I would download, unless you have money just below, and then you can buy the $100 version. But it's kind of nice because it gives you, like, oh, what's that medicine? So it gives you the name of the medicine. And what I like a lot about it is it gives you stuff like, what's the pharmacology, like how's it work, what's the common side effects, what are the reasons not to put someone on it, and understand that the electronic health records, like as you say, I want to be on penicillin, it'll go ding, 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 you're allergic to penicillin, don't give that to them. So in a lot of ways it gets better. The problem is, it's only as good as the data we get. I just had a patient, like, my partner put on something, and it turns out they're allergic. They never told us. It was 15 years ago. We had asked them. Oh, that's right. I'm not good. So it's just, patients are always a challenge to sort of get the information because, frankly, when a patient comes into the office, the psychology of it is they only get about 25 to 30% of what you say. And that's if you're a good communicator. Obviously, I'm not that good a communicator, so I'm sure they get less. So we have to cut them slack, but also understand that, realize that they may not get what we say. Because really, if you come in with any symptom, the patient wants to know, do I have cancer? Do I have cancer? And that's all they're thinking about until I tell them, you do not have cancer. And then they can think about it. So it's very important for us to kind of write things down. I literally have my patients just bring all your medicines in, all your supplements, whichever. As you know, California is sort of the land of fruits and nuts. We have the most expensive urine in the world because we take the most supplements. And so just bring everything in that you do, and then we'll sort it out and see what you're taking and what you're not taking. What's nice about Hippocrates, too, is they have pictures of the pill. So you can kind of see what that looks like and try to validate that a little bit more. So we're really working on the medicines is going to be important. Really working on the different terminology is going to be important. So now to shift gears a little bit to what's going to be on your test. Okay. Did you want to say anything about the whole, like, when they're going to be able to take the test?
Yeah, I just sent out an email. So we're going to purchase the tests, I think July 1st, 2nd, or 3rd. And then we each have, we're going to have a custom login for each one of you guys. So then as time goes on, you're the one in charge of your account, but you'll get access to take the HIPAA test, the MSCAT, and there's also educational materials, so you'll have access to all that pretty shortly here.
So we're going to talk about HIPAA now, and I told you the knock joke. Anyone repeat that knock? All right, so you're not a dad. Yeah, first thing. So a big part of your test is going to be HIPAA, which is the test that basically stands for Health Information Portability and Accountability Act. It was passed in 1996, and basically is trying to give privacy to your data. So think about it, probably health and wealth are the two most important things. So the banks have their sort of security, and they don't get breached. And same with HIPAA. So now that it's electronic, it's very scary that your information can get way out there. So they try to do the best we can to try to keep the security. So you'll hear the word HIPAA a lot, and it's the important reason for electronic health records is that we have a better way to keep patients' health information, and we do a thing called HIE, Health Information Exchange. So if one of my patients goes in the emergency department, that they can break the glass of my EHR and see what's going on with the medicine. And the goal is not to have any of these old records that you can't find it, that the patients actually get to keep their insurance because everything's been confidential. So certain insurance companies can't exclude you from it. So the PHI, you'll hear a lot, it's called Personal Health Information. As you can see, we like big words and then we like abbreviations. And so the PHI is your personal health information. And that's probably the biggest change in medicine over the last, say, 10 to 15 years, is that is you, and you can go, if you go to Kaiser, you have it. If you go to me, it's good. If you go to the university, you all have it. So it cuts down on us, repeating a lot of tests, but it is something that we have to be very careful and protective of. So there's sort of three main parts to HIPAA, and you guys should have all these in hand. Protecting your personal health information, applying the minimum necessary rule to use PHI, and I'll go about that, but to guarantee the patient's right regarding their PHI. So they're going to read what's in there, so you have to be very careful what you write on there, and be very accurate and complimentary, I think, about what you say. So the PHI is both financial information, it's personal information, and obviously it's their medical information. And then the whole idea is that you shouldn't get the whole chart every time. You should get exactly what you need. For a lot of us, it's like, let me get the last note, let me get the images, the last lab, those sorts of things. And that's where you want to have, in a perfect world, you can see how much paper gets done these days. We have what we call note bloat, where the note just gets really big, like it's a sore throat that used to be like 1 page, is now like 15 pages because there's a lot of fluff in there. So as you become a scribe, your doctor or provider will kind of guide you as to how much to put in there and how not to. So for example, every time I'm a primary care doctor, actually secondary care provider, because who's primary care provider? Dr. Google. So get to Dr. Google, and then they can say, Dr. Google said this. So the challenge for me is I need to be very careful about how I do it, but I want it to reflect and not to be too much or too little. So your provider or your doctor will kind of guide you as to how much they want. And again, as I mentioned, there's always 2 reasons someone comes to, like say, us in primary care. One is for what they come in for. The other is for what we call the HCM, healthcare maintenance. So let's say you're a 40-year-old woman, you come in, okay, you're coming in for this, but you probably need, like, make sure you get your mammogram, or you have your pap smear, you have to get your flu shot, or your immunization's up to date. So there's things called HEDIS measures, which I think we talked a little bit about, and that's how they grade us as doctors. So you may be required as a scribe to also look and check on how are they doing on their HEDIS measures, and that's how we can measure. We actually have some of the interns I had this summer that are just calling patients, can you get this done because we get graded, and I gotta get a good grade, and we're gonna come in like at 6 in the morning, if you can't come in, we'll stay late till 8 at night just to get them. So understand that there's a lot of things going in, but the actual note should be accurate but succinct. And so who has to follow the HIPAA? Number 1, the health insurances, the HMOs, company health plans, government payers. So people can't just get into the chart. You have to have a reason for doing it. Obviously, healthcare providers. So if I'm talking to another healthcare provider, we're both kind of under HIPAA, so that's a reasonable thing where I can share the data without getting permission. And then there are healthcare clearinghouses that scan the data. So Big Brother is watching, and there is data that is getting pulled so that we can see population health. So for better or for worse, people are looking at how you or a doctor are treating things. Like we get brownie points for not giving antibiotics to someone with a sore throat if it's a viral infection. I get kudos if I don't do an x-ray on low back pain, because the vast majority don't need x-rays. And so we're trying to not do certain things. On the other hand, I get kudos if I keep my diabetics controlled. And so they're trying to incentivize us to do good care. The problem is, for example, it's a little off topic, but they have these guidelines, they're supposed to follow the guidelines, but they say all diabetics should be on a certain medicine called statins for your cholesterol. But, anybody heard of thalidomide? So thalidomide was a medicine used in the 1950s. They thought it was good for women who have morning sickness when they're pregnant, gave it to them, stopped the morning sickness, but their children came out with like flippers. It was pretty bad. It's a teratogenic medicine. It's a category X. So you're going to see different categories for medicines. Category A is like, it's safe, and we proved it, and no medicine is that, because no one's going to do a lot of these things on women. But B is like, we've used it forever, no problems. So most you can get is category B. Category X is like, don't use it. It's going to cause definite problems with the fetus and the baby. Turns out statins are category X. So like if I have a 22-year-old young female who's diabetic, do I put her on a statin when her chance of getting heart disease is super low? She's a 22-year-old young female versus the risk she's going to get pregnant. So just understand, you may hear about these guidelines and you see us doctors sort of hemming and hawing about it, because the guidelines don't necessarily keep up with the science, and those are changing all the time. But understand that you'll be asked to know what the guidelines are. So when can a hospital or physician's office disclose a patient's PHI? Only if they sign it. So only if a notice of privacy is given to the patient and signed by the patient. So the rule may not apply in events of emergency where the signature is unable to be obtained. So if you come in the emergency room and we have nothing on you, we may have to just use our best judgment, what a reasonable physician would do in that case, because we want to save your life. And then if your computer, like for example, someone gets my password and starts to say what's going on, that's a breach of my EHR. And people get their personal records set out there. That's why I don't give anyone my password. But then we have to actually do a breach notification where we have to tell the Department of Health and Human Services, DHHS, that there's been a breach of our EHR. So as you get into, like the hospital with Cerner, or like say Kaiser with Epic, you're going to be, it's very challenging. You've got to keep your password. You can't tell anyone. Anytime you go into the record, it's going to be paper trail, but it's going to be timestamped to you, and they'll know. So just keep that. Be very, very professional about it. In the old days, it wasn't nearly as guarded as it is now. I think it's a good thing in a lot of ways, but it's a very tough thing because, as you know, computers are computers, and finding the password and making sure the login goes, and you usually change it all. Any questions about HIPAA? So it's a big deal. The more you can learn about it, I would do. So now what I want to do is sort of give you what we give to the first-year med students. So the way I'm tailoring this, because this is not just a straight medical Scribe, because you guys are ideally using the Scribe course as a stepping stone to graduate school and all of that. But this is sort of what you're going to have to document, and this comes from a book called Bates. I'm going to bring the book in and stuff. And it's the first 3 chapters of Bates, so that's our history and physical exam book that we use in most of the medical schools. And I think just knowing what the goal is of a physical exam and the history taking is will help you, I think, to be a better scribe. And then next time we're going to get down to the actual the nuts and bolts of it. But so understand that when you see a patient, it can be either comprehensive or focused. So if you're like a orthopedic surgeon, you're just going to be talking about like the orthopedic stuff, like their left knee. They come in for just their left knee. Whereas a primary care guy, I look at the whole body. I'm not organ specific. And so, but no, I don't do that necessarily at every visit. So you'll hear, is it a comprehensive or a focused visit, and how much should I do? So a comprehensive is typically with a new patient. I'm meeting you for the first time. There's 5 or 6 of those today. And just kind of finding out what is their physical causes related to what they're concerned about. Want to get like a baseline of how they're doing. And then sort of come up with a platform, health education and counseling. So for me, I'm always like trying to move the needle. Like, okay, they're here. There's a nice book called Younger Next Year. That's what I want all my patients. Like, I physiologically want you to be younger next year than you are now. So we kind of go over everything. It gets a little woo, but how's your nutrition, how's your activity, how's your sleep, psychosocial stressors, all of those good things. Focus is just that. Like, it's kind of with established patients. Just had a elite athlete hurt herself. She comes in. I'm going to do a little cursory, but really I'm going to look at that situation, especially in sports medicine, what they're doing. Interestingly, we're supposed to, especially in sports medicine, always check the other side before you check the particular side. We definitely have to make sure we tell them we're checking the other side, because they just think they're just going like, that's swollen, that's not, why are you touching that? So we as doctors have to be very communicative, like, I'm going to check your other side. And frankly, we check it very, very calmly, so that because what the worst thing when someone wants, and any of you have had an injury, don't want someone to touch that where it hurts. So I go over to the other side and just give a very gentle exam, so they know I'm not going to hurt them. Because as soon as you hurt them, you kind of lose them as a patient. Understand, like with the Chargers, if I hurt them, they could really hurt me. So I'm kind of a wuss, and so I will be very gentle with them. But it's usually body system specific. And then the data you're going to get is both subjective and objective. So subjective is really what the patient says, is what the patient tells you. And in a perfect world, you kind of put stuff in quotes. I hurt my left knee, roller skating, and you put that in there. And then you get some of those things we talked about, like the duration, the intensity, what makes it better, modifying things, what makes it worse. And those are things you'll hear about. And then we go through that review of systems, which is sort of that checklist, like a Tuga one you talked about. Like, okay, I know you're here for your knee, but quickly, how about you just kind of go from top to bottom. Anything with your head or eyes, how's your breathing, how's your heart, stomach, dental urinaries, orthopedic, you just kind of go through it just to kind of remind them to make sure they, know about stuff. Then you go to the objective, which is the actual physical exam, starting with the vital signs. And why do they call it vital signs? It's vital. So make sure you always do vital signs on people, and kind of look at that. And as pre-meds and pre-professionals, that you kind of want to look at the old and new, and I think you should, I think personally as a sort of pre-professional scribe, you should be trying to guess your diagnosis. It's a game. It becomes like Sherlock Holmes. Like, okay, they told you this, here's my objective, you see what they do. In a perfect world, you're kind of sort of therapy with your attending, because they like it that you give an idea. Now, you may be totally off. And ideally what you want is a bunch of different, like sore throat could be any number of things. It could be all the way from, oh, it's just a little bit of, a viral infection, or it could be a bacterial infection like strep. There's viral ones like mono, or it could be that you just ate a bad chip when you went to the bar and called that person an SOB. But it could also be leukemia. It could be lymphoma. It could be genetic atresia of that. So there's just a lot of stuff you can do. So my thing is, you don't want to get bored. You want to start thinking what could it possibly be, and kind of help them. They'll go through what's called signs and symptoms. So signs are actually the physical thing you do. Symptoms are what they tell you. So you may hear about signs and symptoms. Signs are actually physical things. Symptoms are what they tell you it is. And so these are your typical things we'll start with. When they come in, they're going to get either triaged, or they have to fill out forms. And ideally, we like them to fill them out online, and then they kind of tell us why they're there. And then you do have to kind of say, well, how reliable are they? If you have worked in the ER at 2:30 in the morning, which means all the bars have closed at 2, 2:30 in the morning is not the best time to get accurate history, because they're drunk and they're going to puke on you. It's not going to be good. So you say, they're maybe less than optimally reliable. Something that tells people they're not that good, but we're not going to say anything about it. Chief complaint is something I think people do a very poor job of. Let's just put, follow-up. Well, follow-up for what? So you should be like, I'm here to follow up for my left knee, or something like that. And ideally, it's like, my knee hurts times 5 days, those sort of things. Present illness is why they're here. Past family social history, and these are things that should be in there, and then obviously the review systems. So typical things, what's your gender, marital status, occupation. I love to know what their occupation is, or their ADL. You'll hear that phrase, activity of daily living. Some people don't have a job, but they work really hard. Like stay-at-home moms work full-time. They never get time. They don't get to pee. And so I have a lot of respect for them. And so, so I'll ask them, what's your activities of daily living? And if you're a student, you're studying. But I like that because it's a non-confrontational question, as opposed to, what's your occupation? And then you want to do the source of the history. Was it from the patient themselves? If it's a newborn, is it the mother that did, or is it the guardian, whoever? And then I always like to know, how did you find me? Did you lose a bet and you have to come see me? Or did someone recommend you? Did you find me online? Did a colleague refer, that kind of stuff. And it just kind of helps me, because what I really am doing is trying to get to know them, where they're coming from in a very short amount of time. And so the other thing too is reliability. If it's something that happened pretty quick, you kind of can be reliable. If it's something like, well, it was like 3 to 5 decades ago, and you're like, I don't know. And that gets tough. How trustworthy is this person, and what's their mood? I had a guy today, like, he hates me. Like, oh, he hates me because he hates me. And so, he just is in pain. A lot of things aren't going right in his life. He did have to wait 15 minutes, and I tried to apologize. And so he's not in a good mood. So I just take that with a grain of salt, kind of like water on a duck's back, just roll it off. And you have to be there for them. And part of that is just the empathy of letting them sort of ventilate, get it all out. Come on, yell at me, tell me how bad I am. And then let's focus back on you. How can we help? So the chief complaint is 1 or 2 symptoms causing them to do care. Make every attempt to quote the patient's own words. That will stay. You don't give the diagnosis in the chief complaint. That's one of the pet peeves is, I'll get these hotshot scribes, okay, you guys, that will come in and go, complaint of UTI, urinary tract infection. You don't know that. They didn't say UTI, you just said that. And so, to me, I like to just say, a complaint of, painful urination or frequent urination, or whatever that is. Present illness, sort of amplifies the chief complaint. It contains the relevant portions of their US systems. And then as you go down, what medications are you on? what allergies, and just, when in doubt, this is when if you have obsessive compulsive disorder, this is where you shine. Because frankly, if you don't have OCD when you go to med school, you will afterwards. Because you just have to be sure. You just have to be sure they're not like pregnant. Like I delivered an 11-year-old girl when she got pregnant when she was 10. Like you have to ask, like, any chance you're pregnant? Are you allergic to this medicine? No, wait, hold on. Any chance you're allergic? Because all it takes is one time. That person takes it, dies, and it's bad for everybody involved.